Good evening and welcome to our discussion tonight on non-surgical treatments for orthopedic conditions. My name is Russell Burgum. I'm a physician with Regenexx in Des Moines. I practice interventional orthobiologics, and I'll go over what that means in a second here. But my background is after medical school, I went through residency in family medicine, and after that went through fellowship training in sports medicine, and am board certified in sports medicine as well as in musculoskeletal ultrasound. And for the last 17 years, I've been practicing non-surgical orthopedics in sports medicine, but for the last probably 13 or 14 years, my practice has been really focused on interventional orthopedics, or if we're talking about what type of procedure or what type of product I'm using in procedure, using patients' own cells and their own tissue, we call that interventional orthobiologics. So the focus today is going to talk about how through using your own cells, your own tissue, how you can avoid elective surgery and avoid corticosteroid injections. Just a little background: Regenexx is the first clinic to ever use patients' bone marrow stem cells to treat orthopedic conditions. And that was done at our flagship clinic in Broomfield, Colorado, the Centeno Schultz Clinic in 2005. So just a little bit about interventional orthobiologics. Yeah, interventional orthobiologics refers to the practice of medicine where we use high-tech, high-resolution imaging to guide needles and other devices to treat orthopedic conditions without surgery. And when we say orthobiologics, that is separating out, indicating that we're not using steroids or drugs, we're using your own cells. So there are two pictures here of a clinic. On the left is an ultrasound suite that shows an ultrasound machine that is used for guiding procedures. And on the right is a fluoroscopy suite. So fluoroscopy is like real-time X-ray. And I utilize both of those in our procedures. So I mentioned Regenexx, that's where stem cell injections are actually invented back in 2005. And ever since those first injections were done, the Regenexx network of practices and clinics has expanded dramatically over the years to where there are now roughly 90 clinics around the country that are Regenexx affiliate clinics. And one of many things that sets us apart is all the procedures that are done in all the different Regenexx clinics are tracked on a patient outcomes registry, meaning before a procedure is done, we ask the patients to fill out a survey, asking them about their pain levels, their symptoms, their functionality level, their what sorts of things can you do and what can't you do. And then after the procedure is done, the patients will get similar surveys at 1 month, 3 months, 6 months, 12 months, 24 months, and every year for 20 years, as long as you've returned the surveys. And as a result, Regenexx has the world's largest orthopedic procedure outcomes database. And we use that to keep track of what conditions can we treat and how well does it work? What products or orthobiologic injections work best for different conditions, such as rotator cuff injuries or osteoarthritis in the joints. And we keep track of what was used, how severe was the condition for For example, does the patient have mild arthritis or severe arthritis? And how much of an improvement did the patient get, and how long did it last? So interventional orthobiologics is, I mentioned we use injectates that facilitate healing of bones, tendons, cartilage, ligaments, muscles, and use precisely guided injections. So there's a spectrum of what types of procedures or injections can be done, from very simple injections, which 95% of physicians in the US do, where it just might be a simple injection into a joint, maybe not even using any type of guidance, just feeling for the spot and injecting it. But more advanced would be what 4% of the physicians would do is using some type of guidance, and even more advanced with that would be interventional orthobiologics, where these pictures show the numerous areas around different joints that we treat. For example, if I'm treating a patient for arthritis of their knee, other clinics would generally just put an injection into the joint. But at Regenexx clinics, we look at the whole functional unit of that joint, and the joints above that, and the joints below that, and the whole connections between them. And we'll treat the various supporting structures around the joint, or tendons or ligaments around the joint that may be wearing out as a result as well. Because not only do you want to treat the wear and tear in the joint, i.e. arthritis, but you have to make sure that that joint is stable. And oftentimes people will develop arthritis because something else is not functioning properly. The joint might be too loose. You may have ligaments that are getting stretched out, and therefore the joint is unstable and wears out. So when you have a procedure at a Regenexx clinic, it's not just one injection, it's numerous locations around that joint to treat the whole region. So what is it? That's kind of a summary of what is interventional orthobiologics. What it is not would be steroid injections. So this shows many of the common steroids that are used in orthopedic clinics, sports medicine clinics, family medicine clinics to treat joint pain, most commonly for arthritis of the knees or shoulders or hips, or for tendinitis in the area. And what I want to stress is, if you come to our clinic, we would not use any of these products. They're used frequently around the world, but the problem is they knock out pain, but these steroids at the concentrations that you see on these vials, which is what is used routinely in orthopedic clinics. And I know because I worked in orthopedic surgery clinics for 16 years. At these doses of steroids are extremely more potent than the steroids that are normally in our body. Our bodies make steroids. We have numerous steroids in our bodies. Some are hormones. There's cortisol. But at these doses, the steroids are actually damaging to cartilage, damaging to ligaments, and damaging to tendons. They may make you feel good for a few months, but they are damaging. So when we talk about corticosteroids, what are corticosteroids or steroids? These are synthetic compounds that resemble cortisol, which our body makes in the adrenal glands. And some of the more common ones here are Kenalog or methylprednisolone or Depomedrol. I'm not talking about the type of steroids like anabolic steroids that are used in pro wrestlers and weightlifters and baseball players until they get caught to make big muscles, and these are not sex hormones like testosterone. So corticosteroids are important. In our body, they reduce swelling and inflammation, and but they also will suppress the immune system. And so in medicine, you can be given steroids by mouth as a pill. It could be given steroids as an injection. There's topical steroids, and there's even inhaled or like nasal steroids. So and there are numerous conditions that you can use steroids to treat. I won't get into all of it, but there are uses for steroids that are actually good. And so I want to talk about the good, the bad, and the ugly of steroids. So there are conditions where a patient needs to have steroids. If you're having acute kidney failure or sudden inflammation in the tissues around the eye, severe asthma attacks. They're used in COVID-19 for patients with severe respiratory distress. There are dermatologic conditions that you need for, or rheumatoid arthritis. The bad would be there's a lot of side effects. Steroids will increase your blood sugars, they increase your appetite. You can get mood changes. Patients can get more anxiety or irritable. If injected improperly, if they're injected in the skin, they can cause thinning of the skin and atrophy or death of fat tissues. So this slide shows a picture of a back of a patient's neck who had an injection, and that area is all shallow and worn down. That it's degraded because the steroid broke down those tissues. And also they suppress your immune system, so you have an increased risk of infection. So there's a lot of inappropriate use of steroids, mainly if you give patients a burst of oral steroids, meaning that oftentimes patients will be given a prescription for oral prednisone to take for several days in a row, but with no real firm diagnosis, just, oh, they're having a lot of pain or they're having back pain, why don't you try some steroids? The other bad part would be most orthopedic use, like tendinitis or muscle injections or bursitis injections or osteoarthritis. The reason is that the steroids at these doses are toxic to tendon cells and toxic to cartilage cells. There's been research on this dating back to the 70s in animals and in the 80s and 90s in humans. And more recently, there's some large population studies showing that patients with knee arthritis have more rapid progression of their arthritis when they're given steroid injections compared to patients who've had nothing or a different type of treatment, let's say a lubricant injection in their knees. So it accelerates your arthritis. Many of the numbing medicines or anesthetics that are mixed in with the steroids are also toxic, especially at higher doses or higher concentrations, such as lidocaine at higher concentrations is toxic to cartilage. At lower concentrations, it's been shown to be safe, but there's one called bupivacaine that's very toxic to cartilage. Back in 2009, there was a highly publicized lawsuit revolving orthopedic surgery where patients had rotator cuff surgery. And what happened was in an attempt to avoid prescribing a lot of narcotic pain medications for the patients after surgery, the idea came up of how about if we insert a tiny little tube called a catheter into the joint and have a pain pump that slowly, periodically pumps a little bit of bupivacaine into the joint to numb it up, to knock out the pain. And that was used for a few years. And then what came up was a large percentage of the patients having these surgeries developed severe shoulder joint arthritis, whereas they had minimal or no arthritis beforehand. These were for rotator cuff surgeries. And it was found that the bupivacaine was toxic to cartilage and was breaking down the patient's joints. And so ever since then, I have made it my own practice had never used that in orthopedic conditions, and pretty much every Regenexx physician I've ever met, everyone knows you don't use bupivacaine. However, I still see notes from clinics, on patients who've been to other clinics where they've had joint injections that have used a mixture of lidocaine or bupivacaine. There's been lots of published data that I talked about. I mentioned of how there are animal studies that go all the way back to the 70s. As recent as 2015, there's a large systemic review in the Orthopedic Journal of Sports Medicine looking at 40 different studies showing detrimental doses of steroids at high doses. And interestingly, it showed that at low doses, at very, very diluted doses, the steroids were actually beneficial to the cartilage. And that is something that we have taken advantage of in Regenexx clinics for many, many years. It's known that if you take a steroid called dexamethasone, a very commonly injected steroid, that if we went back to that slide I showed earlier, the dosage of that, the standard dose is 4 milligrams per milliliter. And a patient may get 1, 2, maybe even 3 milliliters of that steroid injected in a typical orthopedic clinic. It's been shown that if you dilute that to 400 nanograms, which is 1/1000th of the strength, so extremely diluted, that at those doses, it actually stimulates cartilage activity. So unfortunately, that dose of steroid is really used in Regenexx clinics and other orthobiologic clinics that have been educated on this. There have been 2 large studies published in a year and a half ago in November of 2022 at the Radiographic Society of North America. So that's the big annual meeting of radiologists, people who read X-rays and MRIs and CT scans. And I have 2 studies listed here. There was actually a 3rd study that wasn't on steroids, steroid use. It was on the use of non-steroidal anti-inflammatory drugs like ibuprofen and Motrin. That study, interestingly, they looked at patients over the course of 5 years, and they compared patients who were taking non-steroidal anti-inflammatory drugs like Motrin, Aleve, naproxen for their knee arthritis, and followed them for 5 years and compared them with the similarly grouped patients with similar degrees of arthritis who took Tylenol. And after 5 years, the patients who took the non-steroidal anti-inflammatory drugs, when they had MRIs of their knees and evaluation of the joints, those patients actually had more inflammatory issues and more chronic inflammation in the joint and more advanced arthritis than the patients who took Tylenol. The 2 studies that I have listed here are on the impact of steroid injections in the knee and looking at how did the patients who were matched, they matched patients with similar level of arthritis and similar age and similar other medical conditions. And they looked at them over 2 years and compared patients who had steroid injections, patients who had hyaluronic acid called HA, and patients who had no injections whatsoever. In that first study, that was an MRI study. So they would get MRIs of patients before the study and then 2 years later after the study. And what it showed was the group that got steroid injections had significantly worse arthritis. Then the patients with no injections and hyaluronic acid injections had progressively less arthritis. The other study was an X-ray, a radiology X-ray study, and they looked at 50 patients who had steroid injections, 50 who had hyaluronic acid, that's a lubricant. I'll talk about that in a little bit, but if you ever hear of patients saying I'm having rooster comb shots or chicken shots, that's a joint lubricant, hyaluronic acid. And the other group was patients who had no injections. And after 2 years, the steroid group had significant worsening of arthritis compared to the other two groups. So what are some of the alternatives? Well, hyaluronic acid is one. That's what I talked about. That's a lubricant derived from the rooster comb. It first came out as an injection called Synvisc. And since then, and that dates back probably 20 years. And since then, there have been numerous other products to come out on the market. Some of them are one big injection. Some are one injection a week for 3 weeks. Some are one injection a week for 5 weeks. They are generally approved by your insurance as frequently as every 6 months, but no more frequent than that. They do not damage your cartilage. They do provide some relief, generally longer relief than a steroid shot. Steroid injections will typically give you somewhere between 1 and 3 or 4 months of relief. So that's an alternative to steroids. The things I'll talk about will be platelet-rich plasma and bone marrow aspirate concentrate. So platelet-rich plasma is your own blood platelets that are extracted from your blood and mixed in and concentrated into a small volume of plasma. So if we look at if you draw your blood into a vial, into a syringe, let's say, it looks red, and that red appearance is from the red blood cells and hemoglobin. Our blood has several components to it. We've got white cells, we have red cells, we have just the kind of about 35 to 40% of the volume is called plasma. And that's kind of a clear yellow fluid with lots of proteins in it and lots of different growth factors and other products in it. But the big thing that we look at in the plasma are platelets. So platelets are cells, or they're in reality they're actually fragments of another type of cell. But think of them as small cells that are in your blood, and you can separate them out from your blood using a centrifuge, which will separate the red cells from the white cells and the plasma. And the platelets stay in the plasma. So if we take a lot of blood from a patient and separate out the red cells and white cells and keep the plasma with all the platelets in it, and then take this large volume of plasma with platelets all mixed in and take out all the platelets and put them back into just a very small volume of plasma, that's called platelet-rich plasma. So you've taken lots of platelets and made the plasma very rich, very concentrated platelets. That type of procedure has really come into its own in probably in the last 10 years, but even back in the 80s and 90s, it was found that using our own platelets has great effects on helping tendons and ligaments and cartilage to heal. When platelets come into contact with connective tissue, such as skin or ligaments or tendons, the platelets release numerous growth factors to promote healing. Growth factors that promote skin, tendon, cartilage, ligament growth, new blood vessel growth. For instance, when you get a cut, it's the platelets in the blood that stop the bleeding, forming a clot, but also that form the scab and the new skin. So when the platelets release their growth factors, they also stimulate your body's own stem cells in the area to become more active and to start promoting healing. So there are numerous studies on platelet-rich plasma. And the quality of those studies has gotten better and better, where they've really identified how many platelets are we using, what type of what else is in the mixture, meaning are there white cells in the mixture or are there no white cells? And there are numerous studies showing that platelet-rich plasma gives longer relief and more relief than hyaluronic acid, HA. Unfortunately, in the last few years, there have been what we would call fake studies. There have been some well-published studies, 2 or 3 of them in the Journal of the American Medical Association, JAMA, that show that the platelet-rich plasma procedures were equivalent to steroid injections, that they weren't any more effective than steroid injections. And unfortunately, all of those studies were faulty in that the product that they used, the platelet-rich plasma that they used, did not even meet the criteria to be called platelet-rich plasma. There's a criteria that says the number of platelets in the plasma that you're injecting, the concentration of those platelets has to be at least twice what the concentration is normally in your blood. And these studies that were published that showed no significant improvement were only between 1.6 times your normal concentration and 1.8 times the normal concentration. So it did not meet even the criteria, the minimum criteria for platelet-rich plasma. Whereas in our clinic, depending on your age and how advanced your condition is, we may concentrate your platelets to 20 times your normal blood concentration. And that's because there are well-published studies that show that the older we are, the more platelets we need, or the higher concentration platelets we need. And the more advanced your condition is, the more platelets you need. So platelet-rich plasma, it's a great option. For more advanced conditions where the arthritis may be more advanced, or let's say a patient has tears of their tendons, such as the rotator cuff tendon or the ligaments, if you need more growth factors, we extract bone marrow from the back of the pelvis, called the iliac crest. And in that, there are different layers of healing cells, macrophages, hematopoietic stem cells, MSCs called mesenchymal stem cells. And we can extract those layers of cells and use those for treatment of orthopedic conditions. Oops, I went a little too fast there. Sorry, I'm scrolling through. The other thing is a lot you can do to help arthritic or inflammatory conditions is your diet. Your diet, and when a patient has a consultation with me, we spend a lot of time talking about your diet, of things that you can do to help reduce inflammation, including eating more plant-based foods, avoiding foreign proteins like meat, eating lots of berries. Berries like blueberries, raspberries, strawberries, pomegranate have potent anti-inflammatory effects and have what are called antioxidants in them. And they've also been shown to stimulate your own stem cell activity. Avoiding sugar. Sugar is highly inflammatory, especially highly processed corn syrup, and highly processed foods like fast food, ready to make foods that you just pop in the microwave. And so we really talk about doing your own cooking, buying fruits and vegetables, and following more of a Mediterranean diet, which has a high focus on fruits and vegetables, much lower focus on meat. And the meats are used in the Mediterranean diet are predominantly fish, which have lots of anti-inflammatory effects, and healthy oils like olive oil, avocado oil, healthy nuts. These all have omega-3 fatty acids, which decrease inflammation in your joints and in your heart and help protect your brain. So some examples, what is interventional orthobiologics? This is a fluoroscopy or a real-time X-ray procedure showing how we can treat severe arthritis under the kneecap. And in this particular image, on the right, on the top, we have the actual X-ray image showing a skinny needle going in between the kneecap and the thigh bone. That's called the patellofemoral joint, doing an injection on the surface of the cartilage, and a thicker needle called a trocar, a bone trocar, which is actually directed and bored right into the bone to treat the breaking down or the degenerating bone of the kneecap, to help treat the arthritis from the inside out. our cartilage on the surface of the bones gets its nutrition primarily by diffusion through the bone marrow of the bone itself to the surface of the bone. And it also gets some of the nutrition from the joint fluid itself. If you look at that picture on the right lower portion of the screen, that is an MRI image of a patient's kneecap and thigh bone. And the normal bone should be dark, and the white area in the middle is bone marrow of the bone that's breaking down, called a bone marrow lesion. And we see that routinely on MRIs, and there's numerous studies both in the US and in Europe showing that injecting either platelets or bone marrow into those bone marrow lesions can heal them and help prevent the progression of arthritis. So that's one thing we do. Another example would be treating the main ligaments in the middle of the knee, the ACL, the anterior cruciate ligament. We can use fluoroscopy to guide the injection into those ligaments and help ACL tears heal. A shoulder issue here. This shows images of fluoroscopy guided injection into the labrum of the shoulder as well as into the joint. You may hear people may talk about, oh, I have a labrum tear, I need surgery, or we can treat that as well. We can take your platelets and release their growth factors through a process in the lab to create what's called platelet lysate modified. So we can release all the growth factors so that they can take action immediately. And we can inject them around damaged nerves or irritated nerves, such as in the back or in your wrist for carpal tunnel syndrome. And this picture here shows an ultrasound image of a tiny little needle injecting platelet lysate around the median nerve. That is the nerve that goes through your wrist that gets damaged and worn down or irritated with carpal tunnel syndrome. And on ultrasound images, fluid looks dark and more dense structures are bright. So that is a treatment for carpal tunnel syndrome that we do with good success. So why would you want to do this? Why do you want to avoid elective surgery? And elective surgery, what we're talking about is joint replacement surgery or arthroscopic shoulder, arthroscopic knee surgery, or hip surgery. If someone has a broken bone and it's malaligned, or and then there are definite orthopedic conditions that need surgery, that's not elective surgery. But things like treating arthritic conditions or wear and tear, degeneration of tendons, if we use interventional orthobiologic treatments, that's less invasive. There's super skinny little needles. Your recovery time is much quicker. Patients generally are just have to take it easy for a couple days after a procedure and then gradually advance your activities. And you get to preserve your own biomechanics. You get to keep all of your own parts. We don't put an artificial joint in that may or may not be properly aligned, or you may have complications from. So I mentioned one of the orthobiologics we use is platelet-rich plasma. There are many clinics around the country that say we do platelet-rich plasma injections, and the difference at a Regenexx clinic is that we can concentrate your platelet-rich plasma to whatever concentration you need. Every patient that comes through and has an evaluation gets a customized treatment plan depending on their own situation, their own conditions, whereas 95% of the clinics around the country that use platelet-rich plasma do not have their own state-of-the-art lab to customize the concentration of your platelets. They're limited by what type of kits they buy from a device manufacturer to make the platelet-rich plasma. And in those clinics, everyone gets the same dose. Everyone gets the same concentration of platelets, whether you're 90 years old or 20 years old, because the kit that they buy gives them a fixed concentration. And I mentioned we use platelets for more mild conditions or small tears of tendons. I mentioned the platelet lysate is how we actually can release those growth factors. And you think of that as like an immediate, quick release medicine, as opposed to an extended release medicine. Platelets release their growth factors from over the course of 7 to 14 days. So platelet-rich plasma, when injected, those platelets are slowly releasing their growth factors. Platelet lysate, we've already isolated the growth factors, and we often use that in combination with the regular platelet-rich plasma. So then we talk about stem cells. So when we talk about stem cells, we're talking about MSCs, mesenchymal stem cells, that are potent cells that come from the bone marrow aspiration. When we draw the bone marrow out and separate out the layers of the healing cells and the red cells and the cells that we don't use, of all that bone marrow concentrate, a very, very small percentage of those cells are actual stem cells. The others are other healing cells, beneficial cells in the bone marrow. And so those cells that are injected, the main purpose is to stimulate your own innate healing. It's not like they're going to magically convert and become a new joint or be new cartilage. What they do is they stimulate your own cells to repair the area. The MSCs are very potent signaling cells, and they also can help block pain signals. We think of them as a general contractor that is telling all the other cells in the area what to do and how to repair things. And we can concentrate those cells to a much higher level in our lab than a simple bedside centrifuge that's used in other clinics. So what do we use it for? Knee arthritis is probably our most common indication. And I mentioned earlier how Regenexx has the world's largest outcomes registry database. And so we track to see what works and what doesn't, and how long does it work. And based on our registry data, we have found that when using the bone marrow concentrate, even patients with severe knee arthritis are considered good candidates. Every patient that is going to have a procedure, we give you a candidacy rating. Are you a good candidate? Meaning, do we expect you to get many years of relief? Or are you a fair candidate where you have less of maybe a 70% chance of getting many years of relief, or a poor candidate where you might not get any relief, or maybe just get short-term relief? Our knee arthritis patients, even with severe arthritis, are generally considered good candidates. Other things that go into our candidacy rating are, I look at what other medical conditions do you have? What is your whole body healing environment like? If you have multiple medical conditions such as diabetes, heart disease, high cholesterol, hypertension, obesity, all of those tend to make your healing environment less optimal. Similarly with your diet or smoking or excessive alcohol use. So we look at all of that and come up with your candidacy rating. Shoulder, we have great data and good success with partial rotator cuff tears, even full thickness rotator cuff tears, where the tendon edges are still close together and not retracted. ACL tears, the main ligament in the knee, we have great results. So we can help patients avoid knee replacement even in severe arthritis, or in patients with mild arthritis, to slow the progression and help it from getting worse. And patients with meniscus tears, you can help that. So I mentioned our bone marrow procedure. We remove the layers of cells. One's called the Buffy coat. There's another layer that we use, and concentrate that and help use that in conditions that are even more advanced. So we're currently tracking 19,000 knee procedures in the Regenexx outcomes database going back to 2005. And patients will see their improvement by 38% at 1 month, 50% by 3 months, 57% by a year, and see 60% improvement in their condition by 4 years. And function rating, similarly, you see an initial improvement, and it gradually keeps improving and kind of plateaus out at about a year. And if you go to the Regenexx main website, if you just do a Google search on regenexx.com, our outcomes data is available for you to look at. You can search and you can look at conditions treated, and if you look under that section, you can pull down elbow or knee or back or hip, and you can see what the latest data is showing. So even with moderate to severe shoulder arthritis, you can avoid shoulder replacement. Shoulder and hip arthritis are ones that our outcomes data have shown if it's gotten to the severe point, we recommend you not have a procedure with us. We recommend you have a total joint replacement, because again, we've been tracking the data. So we know that if it gets for sure in the hip and also in the shoulder, if it gets to severe arthritis, our outcome data shows you're not a good candidate. Whereas knees, you're still considered a good candidate. So for ACL tears, we can treat partial tears or full thickness tears that are not retracted or separated. But if they're full thickness and retracted, our data shows we can't get it to heal back up. So I showed you earlier some of the pictures about ACL injections. This is actually these aren't my MRI images. These are from the Centeno Schultz Clinic in Colorado. But on the left, that image is a torn ACL. You don't see a discrete dark band of tissue. And 6 months later, there's a thick dark band of ligament tissue there. So there's a lot of hype about stem cells. You may hear it on the radio, you hear ads and magazine articles and people writing books on it. And there's kind of 3 phases of adopting this. And the first is where people learn about it and they think, hey, this is great. It can help everything under the sun. And then as you learn more, you'll start thinking, well, this is great. Then it helps most everybody. But in a more mature thought process is, let's figure out who is a good candidate. And that's what we do in Regenexx clinics. We determine, are you a good candidate? We don't want you to go through a major procedure if we think it's not going to be beneficial. And that brings up the area that we see the biggest abuse in, and that's in amniotic tissue or umbilical cord stem cell treatments that are advertised. This is not something you would get at a Regenexx clinic. We do not do umbilical cord or placenta tissue because there are no live cells in any of these products. When a patient comes to our clinic, and if you have a procedure, we draw your blood or your bone marrow and process it and inject it that very same day. And it's your cells, not someone else's. Amniotic tissue comes from another person, obviously, and it has to be sterilized in order to be used on another person. So the fact that it's been sterilized means there are no live cells in there. There are no live stem cells in any of these amniotic products. Now, people who do these procedures might say, well, but there are other growth factors in the liquid. There may not be live cells, but there are beneficial growth factors. And that's been analyzed at Regenexx and at other institutions, major institutions, and there are some growth factors in these products, but the number of growth factors in these products is less than if you just drew your own blood and injected your blood into the area, let's say your joint or tendon. So these often are not done in a medical doctor's clinic. They're often at a chiropractor clinic. Oftentimes they're done by a nurse practitioner without guidance. At a Regenexx clinic, you will be evaluated and treated only by a physician. And like I said, they're dead cell products. So the key there is, if you see ads about this, if it's a umbilical amniotic type tissue, it's dead tissue. And then actually the FDA regulates that as a dead tissue product. So I would like to leave some time for some questions. I see there are a few things in the chat that I want to get to here in a second. But here's my information. If you'd like to contact us or come in for an evaluation, my email is listed here. The telephone number and our address at the Des Moines Clinic is listed as well. So thank you very much for your time. There's a Oh, darn, so I'm sorry. Someone said I'm unable to see the entire image. Like the image is too small. I had it set for sharing the screen, but it must not have gone through. I'm using a different computer than I normally use, so sorry if you couldn't see everything. I'm sorry about that. That's disappointing. So let me get back. Okay, well, if there are no other questions, I will end here, but again, I want to emphasize that if you come to a Regenexx clinic, and particularly at our clinic in Des Moines, you will get a thorough evaluation. We'll customize your treatment plan, and it's not like other experiences you may have had. Like I know a lot of people have said, "Oh, I went to see an orthopedic doctor and they spent 5 minutes with me." Um, you generally, your time spent with me is going to be somewhere between an hour and 75 minutes, and then we have our patient care coordinator will meet with you. And so it's not just an in and out type visit. It's at least an hour and a half for a typical visit. And we have a raised hand, and I'm trying to get to that. Let's see. Okay, insurance. There's a question about insurance, Blue Cross Blue Shield. So insurance, we accept insurance at our clinic, and your insurance will cover your evaluation, any x-rays or tests that we do. Insurance does not, in general, does not cover the regenerative medicine treatments. They still call it as investigational, which is amazing because there is more published research showing the benefits of regenerative treatments than there are for orthopedic surgery or steroid injections or anything like that. So on the bright side, I mentioned how Regenexx has been tracking their data since 2005. So as a result, Regenexx has approached companies around the country who have their own insurance plans or self-funded insurance plans, showing them how we can avoid surgery at a much lower cost, lower downtime. Patients get back to doing the activities they love quicker and can get back to work quicker. And as a result, there are over 2,000 corporations that will provide Regenexx only regenerative medicine treatments to their employees if they have a condition that would otherwise need surgery. So that's called the Regenexx corporate program. And that has been growing dramatically. But I want to say 4 years ago, there's probably 300 corporations, and now there's over 2,000 corporations that will cover Regenexx treatments for your orthopedic conditions. And one comment, a patient had a stem cell procedure in Omaha in the spine and the same for their knees, and they had great results. So thank you for that feedback. We have in Omaha, we have an affiliate clinic in Omaha that's been doing has a Regenexx clinic for many years, and we're very happy with how well they take care of patients. One person said, "I need to find a treatment for TMJ disorder," and that is something we could talk about. There are regenerative treatments for TMJ. There are also mouth appliance treatments that I personally am not trained in. there's TMJ is definitely treatable. The question is, how badly does it hurt? Wondering about the procedure. So the injections themselves, when we're injecting the platelets or the bone marrow, we use very, very skinny needles. There are some procedures that the ones that I showed where I'm actually going into the bone, those can be quite painful, but we use IV sedation and IV pain medications for those procedures. The bone marrow aspiration, where we draw your bone marrow out of the back of the pelvis, is very well tolerated. And I ask every patient when we do the procedure, I ask them, tell me what you feel. What does it feel like? And 95% will say it's just a weird pressure change feeling. And maybe 2 to 3% will say I didn't feel a single thing, and maybe 2% would say it was terrible. But it's extremely well tolerated, the bone marrow draw. Unlike horror stories you may have heard about patients who've been cancer patients who've had bone marrow biopsies, patients are always amazingly surprised at how little they felt. And like I said, we use IV pain medications, and we can titrate that, meaning use just the smallest amount that we need. And if a patient is having some pain, we can add a little bit more, and so you don't get walloped with a whole bunch of narcotics or sedatives. But it works well. After an injection, we expect you to actually have a little bit more pain, to get a little flared up, because you get a flare up or some inflammation as the platelets or the bone marrow cells are releasing their growth factors. So we expect you to get flared up for 1 to 3 days. But we tell you, we want you to keep that joint moving, do gentle activity, but don't start exercising and working out for a couple of weeks. But keep it moving and keep it warm. We do lots of things to help improve blood flow in the area, because like I mentioned before, we are stimulating your own innate healing. So what we want is to get more of your own cells, from your blood, to migrate into the area. So we actually tell patients use heat, not ice, after a procedure. There are different supports that stimulate blood flow. And so we use all of those to help promote your own innate healing, to help make that that injection that we're doing the most effective as possible. And like I said, we really look at trying to help you with dietary changes, and there are a lot of supplements, dietary supplements, that are effective for decreasing inflammation. The big ones that we recommend is turmeric, omega-3 supplements, fish oil supplements, the extract from grape skins, resveratrol, bitter melon. There are numerous supplements that help with inflammation and help with joint pain. And Regenexx has a extremely advanced research lab in Colorado, and they are able to culture and expand stem cells in the lab and grow cultures of stem cells. And what they've done is they've exposed these cultures to various supplements that are available on the market, and see which ones actually stimulate your stem cells to be more active and to grow more. And similarly, we test different prescription medications, and there are numerous medications that can actually suppress stem cell activity, at least on the Petri dish. So when we have a patient come through for an evaluation, when we're talking about a treatment plan, we also look at what supplements can we encourage you to take, and what medications can we work with your primary doctor to maybe switch off of temporarily, or get onto an alternative medicine for your blood pressure that doesn't suppress your stem cell activity. And someone said, I've been told that the more sore you are after the procedure, the better the results. And do I find that to be true? And I don't think so. I've seen patients have very little pain after a procedure, and then on their follow-ups, because we'll generally follow up 6 weeks later, and then 3 to 4 months later, and sometimes 6 months later. I've had patients who have very little pain after the procedure and get just amazing results. I've had patients who have a lot of pain after the procedure, I get great results. I had some people with a lot of pain after the procedure who get limited results. So I don't think pain is the most important thing, but we do expect patients to have some inflammation, to get a bit of a flare as the platelets or the bone marrow cells are releasing their growth factors. So, but it's the post-procedure flare is generally tolerated with Tylenol. Some procedures we just know from experience are more painful, and will have like a 3-day supply of pain medication like Tramadol or Vicodin or Lortab, but they're not things that ever need long-term pain medications. All right. Okay, well, I think we've got, is there, oh, hold on. There's a question here. It's a question about chronic ACL tear and still having pain in the knee as well as Achilles and the arch. And is this something we can treat? And yes, I often see patients who've had previous surgeries that haven't gone so well, and you know, if when I evaluate a patient, let's say for the knee, we evaluate from the foot all the way up to the low back because it's all connected. So oftentimes patients can have problems with their ankle or their calf or their knee, all stemming from a knee injury. So yes, if you're thinking about, is this something that we can treat? I'd say, come on in and have an evaluation, and we'll look at your studies and look at what type of treatment you had, and then evaluate you thoroughly and let you know what your candidacy is and if we think we can help you or not. There are another question about, do you have heaviness or nerve pain in your extremities, and there are different types of nerve pain. There are problems where the small tiny little nerve endings have been damaged. You call that peripheral neuropathy. And then there are issues more where the nerve might get entrapped, such as coming down your leg. It can get trapped in soft tissue or scar tissue, or it could be an issue coming more from your spine. And so the larger we have less data and less information on treating peripheral neuropathy, but if we have actual nerve fibers that are getting entrapped or nerves themselves that are getting entrapped, we have good treatments for those. So if someone came in with a nerve issue, and if I thought, no, this doesn't fall into what we think, what our data shows or what experience shows that we've had success with, I'd tell you right up front, I don't think this is going to work. If you have a condition where I can identify where the nerve is having an issue, problem, then we would talk about your options. So I encourage you, if you think, if you're wondering if is this something that can be treated, to contact on our website. There's a form that says, am I a candidate? And you type it in what you have and who you are, and our education team will get that and will contact you and go through and give you a good idea of whether they think you're a candidate, or if your condition is something that we can handle or something that we routinely or even occasionally treat, and they can help out with that and get you on our schedule. So the website, Regenexx.com, or the Des Moines Regenexx website, there's a section there for you to fill out your contact information, and our education team can get a hold of you. All right. Well, we are running down to the end, so thank you for your time. We had lots of good questions, and I hope I was able to answer your questions effectively. If not, we can talk in person. But thank you again, and keep your eyes open for other webinars that I may hold about our regenerative treatments. And again, I'm Dr. Burgum, Dr. Russell Burgum at Regenexx Des Moines, and thank you for your time and have a great evening and see you soon. Bye.